Thanks, guys. As Dr. Chow said, my name's Myles. I'm a PGY4 here at U of T. I'm just finishing my echo block. So today I'll be talking about aortopathy and echocardiography. So I'll be talking about a couple learning objectives. I'll be describing the normal anatomy of the aorta, including standard echo measurements and key TTE views for its assessment, differentiate major thoracic aortic pathologies and recognize complications that can be seen with echocardiograms, and evaluate the role of TTE compared to other imaging modalities in diagnosing aortic disease and determining when to refer for surgery. So just looking at the normal aorta first, there's an ascending portion, an aortic arch, and a descending portion that extends into the abdominal aorta. The measurements that are seen here is from a good picture from the European Journal of Echo. In the ascending aorta, it outlines here the typical measurements that you might do. So looking here in the ascending, this will extend into the brachiocephalic or the innominate vein, depending what you call it. They also outline the measurements like the sinus of Valsalva, the sinotubular junction. The aortic arch also consists of, as I said, like the innominate artery, the brachiocephalic artery, as well as the left common carotid and the left subclavian. So I'll go through some of the normal views, just starting from basics. Here, this is a parasternal long axis. People often say looking at the rules of thirds, so seeing that the left atrium is a third, the LVOT or ascending aorta is a third, and the RV is a third of the screen from the probe. And then here you can see the aortic valve and the beginning of the ascending aorta. Then here we see the zoomed in view of the aortic valve. This will be here, help to take your measurements, as well as you can put color on it and see if there's any regurgitation or other complications of aortopathy. And here just outlines some of the other measurements that you'll make. So you'll see here, there's the measurement of the annulus diameter, the sinus of Valsalva, which is usually the largest diameter typically. And then you'll usually get approximately like a 10% reduction into the sinotubular junction. And then as more distally down the ascending aorta, you'll get the proximal ascending aorta. So this just outlines here some of the measurements and how you might take them. So the aortic annular diameter is measured from what we call inner edge to inner edge of the right non-coronary leaflet insertion points at the maximal opening of the valve near mid-systole. That's here. And then for the LVOT diameter, it's as well using a similar inner edge to inner edge methodology. The measurement should be made approximately 3 to 10 millimeters from the valve plane in mid-systole. All measurements are made perpendicular to the long axis of the vessel at the largest dimension using a leading edge to leading edge technique at end diastole. For the rest of these, and several measurements of the aorta are made from the parasternal long axis view and the perpendicular. The measurement of the sinus of Valsalva of the aorta is taken at the maximum diameter of the sinus, which would be here, the line number 1 here. The measurement of the sinotubular junction should be made at the junction of the distal sinuses, which is number 2 here, and the origin of the tubular aorta. And then coming down would be the diameter of the ascending aorta. That's moving to a higher, you can often move to a higher parasternal view to get this more into view and go moving closer to the sternum. If that doesn't work, you can also hold expiration, which may be required to visualize it. And then here, just showing a color that you can place over the valve again to show if there's any kind of regurgitation as well, or turbulent flow. Then looking at a little bit of the ascending and descending, as well as mainly the aortic arch, is the suprasternal notch view, which is usually towards the end of the echo protocol. Here you can see a variety of different structures. You can see the branches, the brachiocephalic, left common carotid, left subclavian, although I'll admit this is probably the best view of any substernal I've ever seen and probably not as ideal. You have the right pulmonary artery that's here in the center, and then the descending aorta that'll come down. And then this is just a live echo view of what you might get from a suprasternal notch. And then here's just showing color that's coming down where you have like red flow moving towards the probe and the ascending aorta, and then descending flow, descending aorta with flow moving away from the probe. And then of course you can always put CW and PW on here for a variety of reasons, which I won't go into today, but I've just put here for your reference. So another view, this is just other views into looking into the aorta. So in the subcostal view, which you can see down here, oh, do you have the mouse, Dr. Chen? So this is subcostal view. You'll see the abdominal aorta here. There's also a view that you can see in the mid part. From the apical view, you can see the mid part of the descending aorta here, just below the left atrium as well. And panel A is just another view of the suprasternal notch. And then here, just showing color as well. You can PW this as well, and just showing flow. So I like this table from the European Journal of Echocardiography. It just outlines kind of the different chambers that you see here and the ways you can visualize the aorta. So looking at the peristernal long and short axis, you can see the ascending and descending, the apical 4-chamber, 2-chamber, and you can see the descending. The suprasternal, you can see quite a lot of it, the ascending, descending, and arch. And the subcostal is mainly the abdominal. On TEE, you can get other visualization as well with an upper esophageal long and short axis. You can see the ascending thoracic, and then from the aortic view, you can see the descending thoracic and arch as well. So it'd be important to talk about the measurements of the aorta. So the normal measurement is taken at the largest diameter, and again with end diastole with leading edge to leading edge. This measurement definitely correlates with body surface area, sex, and as well as age, which is outlined here in this table. And you'll see that kind of the upper limit of normal is usually below, for men is below 4.2 typically, and then for women is below 3.9, again, depending on the age. And you'll see there's a correction factor based on body surface area. So all of these measurements are taken assuming a body surface area of 2 meters squared. But if you're adding 0.5 millimeters, for every 0.5 millimeters you're adding per 0.1 meters squared body surface area above 2 meters squared, or subtracting 0.5 millimeters per 0.1 meters squared body surface area below 2 meters squared, that would be an example of the correction factor that you'd apply for these patients. And then here just outlines again the different points of where you can provide measurements. I won't repeat it again, but the echocardiographic measurements of the aortic root will vary in an individual patient at different levels, and typically will be smallest at the annulus and the largest at the sinus of Valsalva. So I like this graph here that shows, probably many of you have seen from the AHA guidelines, that shows the increased risk that occurs with increasing aortic size. And I was actually quite surprised to see how dramatic it is. So 3.4 or less is still within the normal range, and that's the baseline that they use for relative risk of aortic dissection. And then as you get to the more, still within the normal limit of 3.5 to 3.9, you see there's a 4.55 relative risk increase of aortic dissection. And then once you get to the mild dilatation range as defined by AHA, you'll start seeing a dramatically increased risk of aortic dissection, 89 times the risk. And then once you get to greater than or equal to 44.5 centimeters, it becomes over 6,000 times the risk, which is a quite dramatic increase. The AHA guidelines also recommends moving away from ectasia as a term, but they now prefer to use the term aneurysm. Another way of defining this as well, because it's so your aortic size will be correlated to your height and body surface area and such. They also recommend a more standardized approach that can be used as well as a cross-sectional area to height ratio, which when greater than 10 can be associated with increased risk. So now just to touch on some of the differences in imaging modalities. So there's five main imaging modalities that can be considered to assess the acute aorta, assess for an acute aortic syndrome. So you can use CTA, you can use TTE, TEE, MRA, and angiography. CT and TTE are quite readily available and cost effective. Angiography would be the least available as a whole, but and most costly. In terms of sensitivity and specificity, they're all quite good overall. You'll see that angiography and TTE are one of the more or less sensitive tests, and TTE is one of the more or less specific tests, but still overall quite good. Where echo comes in as a great benefit compared to CT, which is very commonly used and is often readily used as the gold standard, especially in an acute setting, is that CT will not show the presence of regurgitation or other often a lot of valvulopathies, especially for like pericardial effusion. It can show it, but echo would be superior, as well as for coronary artery involvement. TEE and angiography would be more superior to visualize that and would be typically minimally visible in coronary artery compared to others. And then as well, just the more typical things for CT is that it's usually the risks of that is the radiation exposure to it, the fact that it's beneficial because it's non-invasive in comparison to angiography, and the cost as well is not too costly. And of course, echo can be performed at the bedside. So here just talks about a little bit more differences, again, of the different modalities, a table for reference. TTE is 75% diagnostic for type A and 40% for type B. And of course, the added benefits is looking at common complications of this, like aortic regurgitation, regional wall motion abnormalities on TTE, as well as any signs of tamponade if there's a concern for pericardial effusion. And TEE can offer higher sensitivity, but still has limited visualization at times of the upper ascending aorta and arch, in addition to being largely dependent on operator skill and image acquisition. Cross-sectional imaging with CT or MRI has been established as the gold standard for assessment of all segments of the thoracic aorta, including the aortic branch vessels. Just to touch a bit on anatomy before we move into some of the pathology. So the aortic wall is composed of 3 layers, a thin inner intima, a thicker central media, and a thin outer adventitia. The intima is the innermost layer composed of endothelial cells and a thin layer of connective tissue. It provides a smooth surface for blood flow. The media is a thick middle layer made of elastic fibers and smooth muscle, giving the aorta the strength and elasticity to withstand the high pressures. And the adventitia is the outer layer consisting of connective tissue, nerves, and small blood vessels, including the vasa vasorum, which anchors the aorta to surrounding structures and nourishes the outer wall. So here are the 3 most common diseases that are often talked about. So you'll see people talk about a classic dissection. You'll see often a tear in the aortic intima of the aorta, causing blood to split the wall layers and penetrate the aortic media, leading to wall instability. This pushes the dissection flap into the middle of the aorta, separating the true lumen from the false lumen. It is the most severe aortic pathology and often requires and will require urgent treatment. This is in contrast to some other pathologies that are much less talked about, but still relevant, as an intramural hematoma, which often has a circular crescentic thickening of the aortic wall that's greater than 5 millimeters. This occurs when blood leaks into the aortic media at low pressure, forming a thrombus that pushes the outer wall of the aorta outward, leaving a relatively appearing aortic lumen. And this is usually from a rupture of the vasa vasorum. And then lastly, the penetrating aortic ulcer. So you'll see here that it has a crater-like outpouching. So here's some pictures of the 3 that with some jagged edges that's usually associated with an atheroma. And this ulcer allows blood to enter into the aortic media, but atherosclerotic scarring of the aorta typically confines the blood collection, often resulting in a localized dissection or pseudoaneurysm. And then here just talks about the aortic dissection classifications. The 2 main classifications, the DeBakey and the Stanford. The DeBakey system categorizes dissections into type 1, 2, and 3 based on the origin of the intimal tear and the extent of dissection. The type 1 dissection tear originates in the ascending aorta and propagates distally to including the aortic arch and typically the descending aorta. The type 2 dissection tear is confined only to the ascending aorta, and the type 3 dissection tear originates in the descending and propagates most often distally. I like the Stanford classification. I find it more clinically relevant for us and more often used. It's according to whether or not the ascending aorta is involved or not, regardless of the site of origin. So for type A, you'll see here at the bottom, is all dissections involving the ascending aorta, irrespective of the site of the intimal tear. And then type B is all dissections that do not involve the ascending aorta, but including dissections that involve the aortic arch but do spare the ascending. Then to talk about etiologies, so there's a couple categories for why someone might have a thoracic aortic aneurysm. There's heritable conditions that cause aortic disease, like Marfan syndrome, Loeys-Dietz. This all falls under connective tissue as well. Vascular Ehlers-Danlos, smooth muscle dysfunction. And then you'll have your other kind of heritable diseases that are just familial thoracic aortic aneurysms, as well as some other genetic causes. You'll have congenital conditions as well that can lead to aortopathies. So like bicuspid aortic valve, Turner syndrome, and coarctation of the aorta. Then you have your more common, typical degenerative risk factors. So degeneration, atherosclerosis, hypertension, and then of course previous aortic dissection. And then you get into your rheumatological causes like giant cell arteritis, Takayasu, Behçet's disease, and IgG4 related disease or sarcoid. And then you can get infectious causes like bacterial, fungal, and syphilis as well. So here, the AHA guidelines outline sort of the approach of thoracic aortic aneurysms and what to do after discovering one. So it talks about genetic testing is recommended for individuals with syndromic features, family history of thoracic aortic disease, and the early age of disease onset. The thoracic aortic imaging is recommended for first-degree relatives of all individuals with thoracic aortic disease, regardless of age of onset, to detect asymptomatic aneurysms. And positive genetic testing should trigger gene-based management and cascade testing of at-risk relatives. When testing is negative or reveals variants of unknown significance, which can happen quite often, testing is first-degree relatives should undergo screening of some form of aortic imaging anyways. So what are the goals of echo? So the goals of echoes with thoracic aortic aneurysms is to not only confirm the diagnosis, but then look for measurements as well as complications. So you would measure the maximal diameter of the aneurysm, define the longitudinal extent of the aneurysm, measure the diameters of the proximal and distal margins of that aneurysm, determine involvement of the aortic valve, whether that be aortic regurgitation, determine involvement of the aortic arch or other kinds of end organ damage, depending on what aspects of the arch are being affected. And then detect the periaortic hematomas or other signs of leakages, differentiating from other causes which may look like an aortic dissection, like a penetrating aortic ulcer or a hematoma, as well as detecting any signs of a mural thrombus. And then these are conditions that are outlined as well in the literature about that are benign conditions that can often, or other conditions that can mimic aortopathy that's similar to this. So you can have aortitis, atheromatous plaque, prior surgery of the aorta can also mimic this as well, pericardial recess, remnants of a non-patent PDA, artifacts on CT, reverberation, an innominate vein, or periaortic fat, and hemiazygous sheet that may mimic an intramural hematoma. And then here, this is well outlined in terms of the definitions of the main findings of what you may find in association with an aortic dissection. So, of course, you'll define the two flaps, and the goal is mainly to determine which is the true lumen flow and which is the false lumen, and then as well as defining the extension of the aortic dissection. So for you'll look at if it's involving the ascending, the arch, or the descending, or all three. You'll look for the true lumen, you'll look for features such as systolic expansion, diastolic collapse, systolic jet that's directed away from the lumen, an absence of spontaneous contrast, and forward systolic flow. The false lumen will more have a diastolic diameter increase and spontaneous contrast and or thrombus formation, and likely a reverse/delayed or absent flow. You'll look for any kind of false luminal thrombosis, localize any entry tears, assess the presence and the mechanism of mechanisms of aortic regurgitation that may be associated, and we'll get into that later. Assess for any coronary involvement, side branch involvement, pericardial effusions, or signs of tamponade if there is an effusion. So here's just outlining a couple different views of the false and true lumens. So there we go. So in the top panel, you'll see there, it's not playing. I usually should play that. one works for some reason. So in the top view was meant to show a parasternal long axis view with a dissection flap that's visible in the proximal ascending aorta. The bottom left shows a parasternal short axis view with a dissection flap visible in the descending thoracic aorta. And the image that you see below, oh, there, now it's playing. The bottom right you'll see is a parasternal long axis view with aortic regurgitation that you can see by the blue jet going towards the left of the screen. Here's an example of a TEE from a patient with a type A aortic dissection that illustrates the dissection flap indicated by the arrow there that's entering the ostium of the right coronary artery, another potential complication of dissection. So there's many mechanisms to which aortic dissections can, especially in type A aortic dissection, can cause issues with the aortic valve. Aortic regurgitation occurs in approximately 50% of these patients with type A aortic dissection, and the present severity and mechanism will influence surgical decision-making and aid the surgeon in deciding whether to spare, repair, or replace the aortic valve. TEE can also provide further info on the mechanisms as described on the chart there in Table 8 to help with surgical planning. The mechanisms are there that show that you can get it with dilatation of the aortic root, causing incomplete coaptation. You can get cusp prolapse, especially with an asymmetric dissection. You can get disruption of the aortic annular support, resulting in a flail leaflet. You can actually get also invagination or prolapse of the dissection flap through the aortic valve and diastole. And of course, like any pre-existing valve disease could have already existed, like bicuspid aortic valve that could have had pre-existing aortic regurgitation. Below in the echo image, again, you're just seeing the aortic regurgitation associated with an aortic dissection. And then in the image to the right, you'll see a TE image that shows a pericardial effusion. A pericardial effusion in the ascending aortic dissection is an indicator of poor prognosis and suggests rupture of the false lumen in the pericardium. Echo is the best diagnostic technique for estimating the presence and severity of tamponade, and periaortic hematoma and pleural effusions are often best diagnosed by CT in the acute setting, and the presence of periaortic hematoma has also been related to increased mortality. So the European Journal outlines a very nice table that talks about the differences in evaluating a true lumen versus a false lumen. The true lumen often being smaller than the false in size. You'll have a systolic expansion and pulsation for the true lumen and a systolic antegrade flow. You'll get a communication from the true to the false lumen in systole, as well as early and fast contrast echo flow. False lumen being mostly opposite to these that I just said for the true lumen. And then here is just showing some images that are there for in an aortic dissection, color helping you evaluate where the true lumen is versus the false lumen being showing no color flow. So just to briefly talk about intramural hematoma and penetrating aortic ulcers, the key points for IMHs are to represent, are showing that there's an absence of a dissection flap between a double-channeled aorta on echo. You'll often see a more crescentic or concentric thickening of the aortic wall. It can progress to localized frank dissection or rupture. The thickness and maximal aortic diameter predict risk of progression, and CT appearance is high attenuation, eccentric or concentric wall thickening on non-contrast images. At inexperienced centers, you can also very often miss subtle wall thickening for IMH. Penetrating aortic ulcers, important factors to report would be the lesion location, the lesion width, length, and depth, the aortic diameter at the level of the lesion, the presence or the extent of the IMH, contrast extension beyond or outside the aortic wall, mediastinal hematoma, pleural effusion, and the presence and length of a false lumen. So here's just an image showing an intramural hematoma due to a penetrating aortic ulcer, as indicated by the arrow over here. And is shown in a TE short axis view in the ascending aorta, and by IVUS in the image on the right, in the descending aorta, and you can note the thickening with the bidirectional double arrow that's here, showing the hematoma. So it'd be important to talk about what we do after we get these measurements. Depending on the underlying cause and the background history of the patient, will determine what the threshold is, and it can be quite variable for when to refer a patient for consideration of surgery of some kind. So for non-syndromic heritable thoracic aortic disease, typically this is a shared decision-making approach when patients have aneurysms such as these. That's done at multidisciplinary centers, as well as for asymptomatic patients of this this background. Typically, repair is considered when the maximum diameter reaches over 5 centimeters. And then it'd be important to talk about Marfan syndrome, which is for background, is an autosomal dominant connective tissue disorder. Patients with Marfan syndrome develop aneurysms involving the aortic root, or the sinuses of Valsalva, and are at risk for aortic dissection, notoriously. Descending aortic and AAAs are less common. Echoes recommended at the time per the AHA guidelines at the time of diagnosis, and then 6 months after. If it's stable, then you typically do an annual echo for these patients, and if inadequate visualization, then a CT or MRI should be considered. If a replacement has already occurred, then further imaging with MRI or CT rather than echo should be done to look for distal thoracic aorta disease on a routine basis. And greater than or equal to 5 centimeters for these patients is typically the indication to refer for surgery to replace the aortic root and the ascending aorta. The AHA also outlines here high-risk features, which can also help in decision-making and can include family history of aortopathy, rapid growth of the aorta, 0.3 centimeters per year or more, and diffuse dilatation or vertebral artery tortuosity. Another type of disorder that's associated with dissections is Loeys-Dietz syndrome. So this is characterized by aortic and branch vessel aneurysms, and dissections, arterial tortuosity, and skeletal features similar to those of Marfan's. Patients with Loeys-Dietz syndromes are at risk for widespread aortic and branch vessel aneurysmal disease and dissections. Again, a baseline echo is recommended to assess for any aortopathy, as well as 6 months after to see the interim growth. If it's stable, then an annual imaging of some kind can be done. And if known dilatation or dissection, then they will need MRI or CT annually as per the guidelines. Surgical thresholds are variable in this population and not so simplistic. They're based on a variety of factors, including the genetic variant. You can see it in this table in the bottom right below. The genetic variant, the presence of high-risk features that I had mentioned previously, and this can range anywhere between 4 to 5 centimeters, again, dependent on these factors. Then moving on to Turner syndrome, which affects about 1 in 2,500 live-born girls, typically results from complete or partial loss of the second X chromosome in all or some of the cells of an individual. And approximately 50% of patients with Turner syndrome have cardiovascular defects that include bicuspid aortic valve, approximately 15 to 30% of patients, aortic coarctation, 7 to 18% of patients, and ascending aortic dilatation, which is up to 33% of patients. And because of Turner syndrome, because the patients with this have a shorter stature typically, type A aortic dissection may occur at relatively small aortic diameters consequently. And so AHA guidelines often recommends indexing the aortic diameter to body size, including calculating something called the ASI for monitoring. At time of diagnosis, they require echo and a cardiac MRI to look for bicuspid aortic valve, dilatation of the aortic, and coarctation. And then if there are no risk factors, imaging can be done for this population group every 10 years for adults. If the ASI is greater than 2.3, then this is because then this becomes annual imaging, but they do not specify the exact type of imaging modality for the annual surveillance. The surgical cutoffs are, again, quite variable based on genetic variants, the presence of risk factors, and can range anywhere between 4 and 4.5 centimeters, again, indicating that these are usually smaller targets of absolute values of aortic diameter. The last major one I'll talk about today is bicuspid aortic valve. So that's a common congenital valve condition affecting approximately 1% of the population, with a 2 to 3 to 1 male to female predominance. It typically occurs sporadically, but may often be inherited in an autosomal dominant pattern with variable penetrance. So looking for a familial history and family screening can also be indicated. It can also be associated with other congenital or cardiovascular defects, and these patients are at risk for infective endocarditis. Patients with a bicuspid aortic valve often have aortic dilatation or aneurysms affecting the aortic root, the ascending aorta, or both, with the prevalence of aortic aneurysm increasing with age. Echoes indicated to assess aortic, all these factors, and if not sufficient, then CT or MRI. If aortopathy is present with a bicuspid aortic valve, then you should be screening all first-degree relatives. And if the diameter with bicuspid aortic valve is greater than or equal to 5.5 centimeters, then surgical replacement is indicated, or at least should be considered. And the risk factors as well include for aortic dissection in these patients is family history of the same, aortic growth rate greater than or equal to 0.3 centimeters per year, and aortic coarctation coexistence. And just to briefly talk about guidelines that are a bit more discrepant and less major ones that are discussed in the AHA guidelines at the least, which are the most commonly used. For vascular Ehlers-Danlos, CCS defines a threshold of 4.2 centimeters for operative management, but likely it's more complex than this. And then family aortopathy is 4.5 to 5 centimeters as per AHA, and more 4.5 centimeters as for CCS. And then lastly, if they're going for cardiac surgery for another reason, a possible intervention on the aorta would be 5 centimeters for in diameter for AHA, and 4.5 centimeters as per the CCS guidelines. Thank you for listening. I wanted to end off with posing a question to the audience that I think would be helpful for myself, and I think a lot of other people that I've come across have asked the same question, is in clinical practice, I think we often find there's variable reporting on ascending aortic dilatation, on echo depending on the center that's doing it, as well as I'll see variable clinical practice in terms of when and how to follow up these patients at what thresholds. Should you keep a patient in your practice for life if they're having any sign of dilatation at a certain threshold? Or is this something that you can follow for an interim, look for risk factors, and then discharge in an outpatient setting?
So thank you, Myles, for reviewing this topic, and glad to see one of my former mentors from Mass General, now is Mass General Brigham. It's, Dr. Eric Isobaka is still very active in publishing in this area, has been doing this for the last 35 years, as far as I can tell. And a number of our colleagues has been associated with groups and the aortic diseases, including former lab director Dr. Stuart Hutchinson, and also Dr. Mark Peterson. We're very interested in this area of aorta, so you can make a whole career on this. And so to answer your question, let me pass it on to my colleagues and see what they say, because I have also the same question about dealing with it. It does actually take up quite a bit of your clinical times. When you look at all the patients that you see in your list, and not infrequently, I have about 5 to 10% of my clinical times taken up by asymptomatic mild aortic dilatation in the range of somewhere between 40 to 45. So, I used to follow everyone that is slightly dilated, but I think I'm going to make the cutoff for myself at 40, although it's not in any guidelines. But when you look at the number of people that you follow, if it's below 40 and keep following them, you have so many that you can't really handle, I would say, on a practical basis. 40, then I start considering. So let's see what my colleagues have to say. It is a very controversial area, and somewhat lack of guidelines directed.
I was surprised this wasn't elucidated more in the guidelines in my readings.
Yeah, I think part of that is that I don't think we have a lot of good data in terms of kind of outcomes in that range per se. So it ends up being very individualized. So I think you kind of mentioned this, Myles. I think when you first see a patient, we get referred to patients for a dilated ascending aorta or aortic root for that matter. Looking at risk factors, I think hypertension is a big part of that. Family history as well in terms of any possible familial predisposition. And in the absence of those, if it's only mildly dilated, I probably say at least one follow-up at a period of time, whether it's 6 or 12 months. And if it's mild, I'd probably go a year. But if it's moderate, then I'd probably go 6 months just to see if there's that rapid rise of rapid increase. And depending on if it's stable, let's say after that first follow-up, then if there's nothing else, I think as an individual decision as to whether a cardiologist would want to continue to follow, because in the end of the day, at least in Ontario, echoes are pretty easy to get, and a family doctor can easily take care of that. And if obviously there's been a change, then we can refer back. Once it gets beyond 4.5 and you get into that more moderate range, depending on all the factors, you can see the cutoffs are variable depending on the overall condition. Then you might be you probably would continue to follow, especially if they have risk factors like hypertension.
Yeah, I agree with those comments. I think Chi-Ming actually puts a comment in when he reports these back in terms of what defines rapid growth, which is 0.3 centimeters per year.
0.5 centimeters per year of growth is an indication for consideration of surgery or very close follow-up.
I think in the absence of that, every couple of years is fine, and if it's mild, can probably be followed by the referring physician, unless there's other complicating factors. I think bicuspid valves are an example of where you would follow it more closely and follow it yourself. I think the other issue is even within our own lab, there's a lot of variation in what gets called mild or borderline aortic root dilatation. And what I use now is I use the ACE calculator, and if it says mild or borderline, then I would list it as that and then suggest the follow-ups.
I'll tell you my version of looking at it. First of all, I spoke to some of the people actually behind these Canadian and US guidelines. Often they actually don't want to say that. Part of it is actually because of the legality behind it. So over the years, I asked them, how should I follow these patients? And then, in US, there's more legal aspects surrounding all these. So that's why they're very much shying away from it. My personal practice, I start following them 40 or above or suggest follow-up. Usually I do it in 1 year because otherwise I wouldn't know where they are and in terms of the growth. And then if they're stable, I do it every 2 years. And then, in Ontario, if possible, I'll pass it back to the family doctor because it does take up quite a bit of our practice to try to deal with patients. And also, having patients keep coming back to see us. The other thing that I urge our sonographer colleague to help us, and this is one of the major problems I face especially in the community, is year after year. So 1 year you'll be finding someone who has a approximately ascending aorta of 46. Okay, then the next year the report comes back at 39 or 42. So the reason depends on how far you look, right? In the proximal ascending aorta, whether you did your right parasternal, etc. Because it's really, the thing can go like this. And you look at over here, then it's going to be not very big. And you look where it's supposed to be looking for further down, then it may be there. So it's important for sonographers to really help us, because otherwise the patient is asked, is like, did my aorta really shrink over time, and should I forget about follow-up? So those are the things we actually run into not infrequently. And so the message to our sonographer colleagues and people online is that if people are referred back for aortic dilatation, before you say it's normal, look back at the old reports to see what it was, okay? And if it happens to have access to a previous image, please look at it and see where it was obtained. Is it from the parasternal long axis view? Is that the right parasternal views, etc., etc.? And this is a very important point, because I not infrequently run into this thing. It's like, because then I end up having to either repeat the echo study, have the patient do the echo with me at the same time, or I end up actually doing a CT scan to try to figure out what's going on, because it's really hard to follow these patients if they are not consistent. So knowing where it was before, and then you look at your numbers this year.
I think the other technical components are, and you highlighted, need to be perpendicular to the long axis. Right? All it takes is to be a little tangential, and the values are substantially different. And to make sure that you're consistently either going leading edge to leading edge measurements.
Yeah, one thing just to reemphasize, I think you probably mentioned it, but I'll reemphasize it again. For all the aortic dimensions, including the proximal ascending aorta as well as the aortic root should be leading edge to leading edge, and it should be done at the end diastole, which is when the aortic valve is closed. So those are all the timing. You're going to ask why leading edge to leading edge. Have you ever considered that question? You just take it, it's like, okay, LR to LR, or LE to LE. So it's because in the chamber quantification guideline in 2005 and 2015, they find that way is the best way to correlate with CT scan. If we do inner edge to inner edge, you tend to underestimate by about 1 or 2 millimeter. So that was actually the motivation behind it, why we do leading edge to leading edge in terms of correlation with CT. CT tends to measure a bit bigger than what we do in echo. Okay, so sonographer colleagues group, any thoughts on the aorta? Is that a pain for you, or necessary evil, or any scanning tips? Okay, so Vin, do you have any scanning tips for us? You taught me a few things over the years, I remember.
You get multiple views. Position is very important. Has to be that lateral to this position. Because, as you know, if it's supine, it will be hard to see. There is no, hard to see the view. Again, pay attention to the measurements and not said. If it's being followed out by or the viewer, I really have to take time. Really have to take time. Take more. Make sure a measurement error you can have a measurement error. Maybe 1 to 3 millimeters. That's important, but at least. But if your measurement is about 4.5 and measurement error of 0.3, that's significant, because that's where we say aneurysm, right? So then it's good.
Now, one of the other technical tips I learned from my sonographer colleagues over the years is, if you want to really be precise for documenting the proximal ascending aorta, you measure it, let's say it's 4.5, you can further say that it's measured from 6 centimeters away from the annulus. So you draw another line from the annulus where the aortic leaflet meets the aortic wall and measure it out. So next time when the sonographer does it again for follow-up, then you know is how far they've measured it. Because the aorta is not like a tube where it's like the TTC train track, right? Sometimes it goes this way, sometimes it goes this way and then come back again. So knowing how far it is from the annulus is actually useful. So that's sort of surrogates from having the original images.
Yeah, I'll make an additional point. A lot of times, the sonographers know this. They have to go one rib face above where they see the root to get the ascending aorta. And unfortunately, on that view, you can't see the sinuses. It's quite common. So getting that measurement might be a little bit difficult. The other thing I think is useful is that once you get to beyond a certain size, especially solidly in that moderate range, 45 to 50, depending on the underlying pathology, it might be worthwhile to get another cross-sectional imaging study like a CD, just for correlation. And if it correlates well, then you know that you could probably continue to follow by echo. But if there's a miscorrelation, then you may have to rethink about whether echo is the best modality to follow some of these patients if you're looking at, especially when they get close to cutoffs. Because there are challenges for imaging.
Now, often, not in frequency, I would do a CT, especially people with bicuspid aortic valve. So whenever I almost always do a CT at the baseline, because you don't know where it goes, like where. So they can be actually dilated much later, like beyond what we see on the echo. Actually, we only see on echo we can only see pretty much the first 7 centimeters up to 8 at most, because then it can be dilated further down, and we have seen that. Any other comments from more of our senior or experienced sonographer colleagues like Emily, Packer, or Lindsay? You have done this a long time. Any practical tips that you can give on our sonographer colleagues online? Everything is very clear. Okay.
Chi Ming, it's Bob Howard.
Hi, Bob.
Hi, I wonder if Tom could talk a little bit about genetic testing.
How long do you have, Bob? I think it was actually highlighted in the talk. Like most forms of genetic testing, it is around identifying in those either syndromic or well-defined genetic causes. There's now extensive gene panels for that testing. In fact, our own aortic clinic does that. And similar to other genetic cardiac conditions like hypertrophic cardiomyopathy, the follow-ups are very similar, right? If the genetic testing is negative, then it's ongoing imaging follow-up. If the genetic testing is positive, then first-degree relatives can be offered genetic testing as a risk assessment. And that's true for most of these conditions as well. And you can see actually the complexity of genetic testing is pretty great in this variety of syndromes. Some of the conditions have, clear genetic causes that involve 7 or 8 different genes and multiple different genetic abnormalities. But the general rule is the same. If it's positive, you can use it for family screening. If it's negative, you have to continue imaging.
Yep. So there's a comment on the from an iPhone on the chat. In a young person, MRI is probably better for long-term follow-up rather than CT, decreased radiation risk. Cannot agree more. I wish I have my own private MRI facility because to get MRI it's like a year, but which is fine, for aorta because you can wait. But it is, yes, depends on which country you're in and availability of image modalities and cost is also a factor. Yes, I completely agree with you.
Yeah.
And
so availability is a big issue for MRI. And the other aspect is just the patient as well. I think CTs are just so fast. Agree with radiation and contrast risk. MRIs, you wait longer and it's a more involved test for patients. And some patients just don't like to get in the magnets, but CTs are so fast. Yes.
It'll actually be interesting to see how the technology develops, given that there are now bedside MRIs that we're using in ICU, and as those continue to develop, they offer other opportunities for this kind of screening.
And on my YouTube advertisement, you can get a whole body MRI in Ontario now, but you have to pay for it. But moving along, I'm going to ask this provocative question that I've always asked in this kind of lecture: is when or should we do indexed aortic root size or approximate ascending aorta size? There was a time in 2015 Chamber Quantification Guideline that talks about that, called the aortic root index or aorta index. Should we use that routinely in terms of indexing the body surface area?
The guidelines do, from what I saw there, did recommend for body surface area and adjusting accordingly. But it's discrepant based on the resource that you look at, and they give other options as well. So I'm not entirely sure what's generally used.
Yeah, we've talked about this before. Unfortunately, the treatment guidelines use absolute dimensions. Although I know Mark Peterson used to definitely take body surface area and or height in recommendations depending on underlying pathology. But it doesn't make sense, right? BSA is more problematic just because significant increases in weight can certainly affect BSA that may not necessarily kind of reflect true body habitus for a ascending aorta.
And I think the other patient population where it is used for decision making is the pediatric population, where the Z scores are actually used as part of clinical decision.
Yeah, there's a Sick Kids version of it, and there's a Boston version of it. Yes, I have been very interested in this question for a number of years because I've done the calculator. If you actually look at the CardioMath calculator, it's actually there. And we actually used it for a while. But then we realized none of our clinicians actually use it or even look at it, except for a few surgeons when they try to trying to decide on the edge whether they want to operate or not. And rather than looking the absolute number, they would go back to adjust themselves the body size. So they look at the patient in front of you as 4'8", and with a size of 5.2 or centimeters, then, and with that number calculation, they, it pushed them towards actually operating because they will eventually need it. That was the argument that was given to me. Oh, Lean has a question.
Myles, who uses that cross-sectional area index?
Cross-sectional area, I'd have to look back. Let's take a look here.
It's probably from that's definitely not from it.
You're talking the one that was over 10?
Yeah, we don't tend to do that.
Yeah, because we don't get cross-sectional.
That was AHA.
Although you can make an argument that if you do the proximal ascending aorta, you just like flip the biplane on, then you get both. But that's something maybe worth thinking about as a research.
Just ask a quick question. Practically speaking, for aortic dissection, have you guys ever had a case where you see the dissection on echo, all the cardiac surgeon, if they're okay with that and they want to move ahead, or is it always the case that they're going to want to get a CT study?
I think the CT probably gives you more information about the extent of flap. I think for surgical planning, it's probably still utilized.
Yeah.
If you have a good T, maybe, but not transthoracic.
Yeah. Well, in a clinical setting, depends on what you're dealing with in front of you. If someone, looks like a zebra, sounds like a zebra, and happens to have a nice flap that has all the features in terms of independent mobility and the colorful reflexes and et cetera, and which Dr. Eric Isobaka actually proposed almost 25 years ago in a New England Journal of Medicine article. And then there's reasonable indication to go ahead, and they can consider like doing an urgent TE or doing an intraoperative TE just before you go in. So that's another scenario. You have to remember, we also started at a period of time before CT was available for these kind of things. So we used to get called in as a echo fellow, echo staff to actually do all the TEs for aortic dissections before they go in. So doing TAV before is also clinical decision how urgent the patient is. So yes, the answer is yes. I have seen it to do transthoracic. You make a diagnosis, you follow everything that you could follow, and then you do TE afterwards because sometimes patients are not stable enough to go to CT, and we have seen those too. Keep questions.
Pretty rare though.
Yeah.
That's funny that in this day and age, the times that we've detected a dissection on a TT is just pure chance. Patient had an echo order for something else, and they didn't really suspect the aortic dissection. If the aortic dissection is suspected, they'll order CT.
Yeah.
In fact, those ones are more often chronic than haven't been.
No, it's true. They're the ones who kind of walking off the street as the fluids emerge.
Because the flow is you show up and you emerge and they're worried about it, they're getting a CT.
Yeah. Well, it's rarely like renal patients as well, and we don't get a CT, then we move to TT and T. The T is more specific, obviously.
Yeah. I mean, there are papers on this, and in terms of sensitivity and specificity, TT is around 40, 45, 55, somewhere in that range. Sensitivity-wise, it doesn't mean that you can't see it, but if you don't see it, it doesn't mean that it's not there.